Our next speaker is Professor Ferrari, Roberto Ferrari. He doesn't need an introduction, even with this voice. He's a world figure in the field of cardiology. He's the ex-president of the European Cardiac Society, and he is going to talk about hypertension, what is more important than in life. Thank you very much, Dr. Roberto.
Thank you, and a very good morning to all of you. It's a great pleasure for me to be back to Saudi Arabia, and particularly here to Jeddah. This morning I had the chance of jogging a little bit on the promenade, and it was really very, very nice. These are my disclosure, and I will start to saying that there is a very clear relationship between blood pressure or elevated blood pressure and outcome. And indeed, if we can control the blood pressure, we will be able to reduce the outcome. Unfortunately, I cannot point, and there is no... sorry? Here. Yeah, but it doesn't work. Yes, but the pointer.
Yeah.
The pointer doesn't work. Okay. All right. And so you have to look the slides yourself without the help of a pointer. And as you know, rather recently in the United States, the guidelines have further reduced the target that we should reach for blood pressure to below 120 and 80. And this was mainly based on the results of the SPRINT trial and on a few meta-analyses. But all of you knows the problems that the SPRINT trial has created, particularly because the way how they did take the blood pressure, which is the appropriate way, but it is not what we are normally doing in our practice. The European guidelines also have reduced the target, but just below 130 and 80. And further, if this is achievable without too many effort. And this sentence is very important. In other words, you should not have to insist to reduce the blood pressure below 130, because what you are gaining in terms of outcome is very, very little. And therefore, if it is do. But if you have to put a lot of effort, forget about this. Now, you may ask why such drastic differences. And I believe that in US, it is just one country. They speak one language. They are very pragmatic. Do it. 2 studies are suggesting this. We don't really look whether these 2 studies has been done. Just do it and don't think about it. In Europe, and I should say at the EAC, by definition, we are a federation of more than 56 countries speaking 37 different languages, and we need to adapt. We need to be political. We need to come to sometime more logical conclusion. And I didn't know what you are doing in Saudi Arabia, but I just had the opportunity to look at your guidelines because they were in my Congress bag, and I'm very pleased that you are following the ESC. That is very good. Now, there are, however, several considerations that we need to make. Because beside which guidelines you like to follow, the context is that the medical community, as you are not able, in the majority of the patients, even to reduce the blood pressure below 140. And we are always discussing in congresses how low we should go. But the reality is that patients are not really well treated. I give you an example. In Europe, 45% of patients with coronary artery disease who know that they are hypertensive, they remain hypertensive. 45%. This is an enormous amount of patients. And we are not really able to fully treat all the patients with hypertension. And that is true everywhere in the world. It is true in the US, particularly in the US. It is true in Asia, and I'm sure it is true also here in Saudi Arabia. And this, of course, is bad, because treatment of hypertension is very important. Now, which are the reasons for that? And what we are going to do about this? It is because the drugs do not work? No. We have several very effective drugs. It is because they are too expensive? No. In Europe, all the antihypertensive drugs are generic nowadays. It is because the patients do not take the pills? Yes. Probably this is one of the reasons. And another reason is that we, physicians, are not good enough to make the patients taking the pill. We are not good enough to convince the patients that taking the pills is very important. Sometimes probably we don't escalate or we don't counsel our patients enough. Sometimes we are worried about the guidelines, which are needless complicated. The important thing in front of a patient with high blood pressure is just to reduce it without thinking too much about the guidelines. And there are also other problems, because the pathophysiology of hypertension is very heterogeneous. And hypertension is a simple disease because I can measure it. But if I'm asking you to tell me the reason for hypertension and what is the pathophysiological problems of hypertension, is not an easy question, believe me. And why some people get high blood pressure is not an easy explanation. And also, blood pressure has multiple regulatory mechanisms, and not a single drug mechanism of action probably will be sufficient. And therefore, both the USA and the ESC guidelines are nowadays in agreement that combination therapy for hypertension is important. And perhaps we should start immediately with combination therapy, because sooner or later we will end with combination therapy. And of course, this has been shown that it is much more effective to add another drug than to increase the dose of the single drug. And so combination combination therapy is really very, very important. I have to go back. Can I? And I like to concentrate today on the possibility to reduce the renin-angiotensin system, and I will ask myself the question whether it is better to do that with an ACE inhibitor or with an ARB, because I believe that this is really an important question. Now, this system, it's a very important system which is there for millions of years, from the aneloids to the man. Its short activation is very useful for the maintenance of the species, and the system is there in order to avoid or to reduce bleeding. And this is because, as you know, angiotensin II is a very strong vasoconstrictor, and also it causes hypertrophy and repair. And by causing vasoconstrictions, of course, an excess of angiotensin II increases blood pressure. And this is a very good mechanism during hunting for the animals to avoid unnecessary bleeding. The problem is that overproduction of angiotensin II through the time causes vasoconstriction, hypertrophy, platelet aggregation. And we heard just a minute ago how important is hypertrophy for the prognosis of patients with high blood pressure. And in addition, there is a balance between angiotensin II and bradykinin. So if you have a prolonged activation of the renin-angiotensin system, you will have less bradykinin, which is important because is, and we will see why, is a very cardioprotective agent. So, not surprisingly, an overactivation of the renin-angiotensin system is found in many important diseases with which we have to deal every day. The first one being hypertension. And it is also important to remind you that this system is not only circulating, the ACE enzyme is not only in the blood, but it is also in the tissue, and it is also in the vessels. And that is the ACE that we need to target in a patient with hypertension. And now I would like to provide you my view, and although I said that I had been working with many drug companies, you have to understand that for 20 years I've been working with Perindopril and Perindopril arginine. So I might be biased in what I'm going to tell you, although I think I am not biased, and I will always provide you the evidence for what I'm going to tell you. Now, I don't have to come to Jeddah to tell you that Perindopril is a good antihypertensive agent, and also it is a very good and long-lasting antihypertensive agent. This is very known to all of you. What I am interested to is the fact that we do have several data, and these are just some of the data, but we have now more than 60,000 patients randomized to either placebo or Perindopril in many different clinical trials and always producing extremely good results in terms of the best of the endpoint, which is all-cause mortality. You can see the results of Advance, Europa, and Progress, and it's quite interesting that Progress is the only randomized clinical trial in which an ACE inhibitor has been able to reduce also stroke in addition to myocardial infarction and so on. Now, the question is whether all the ACE inhibitors are cardioprotective, and the answer is not. Here, you can see 4 trials, the QUIET trial, in which we use quinapril, and unfortunately, quinapril did not improve the outcome. Then there was the HOPE trial, and there we use ramipril, and the HOPE trial treated the patients at high risk for cardiovascular disease. And as you can see, the trial was stopped earlier because ramipril was better than placebo in reduce the outcome in terms of cardiovascular death, myocardial infarction, and stroke. And then we did Europa using Perindopril. I was the chairman of the Europa trial, and Europa enlarged the patients with coronary artery disease, not necessarily at high risk, but at no risk. And you can see that, again, Perindopril was very successful. And then there was the PEACE trial, which used Trondopril and targeted almost exactly the same patients than in Europa. And unfortunately, there was no improvement in outcome. Oh, sorry. The question is, why this difference? Because you see, one explanation is that ACE inhibitors may be cardioprotective because they are reducing blood pressure. And the blood pressure is a risk for myocardial infarction. But the problem is that Trondopril and QUIET, they did reduce blood pressure even more than quinapril and ramipril. So must be something else to explain this good prognostic effect of ramipril and Perindopril. And, no, sorry. And so the question is, which is the mechanism? Is the protection of Perindopril specific? And do we have evidence that the ARB provide the same level of protection? And also, is there any other mechanism than just reduction of blood pressure? And I believe that the effect of the ACE inhibitors on the endothelium is very important. And the reason why I believe that is because when I'm saying cardioprotection, I mean reduction of myocardial infarction. And a myocardial infarction, to me, is not a disease of the heart, but is a disease of the endothelium of the coronary artery of the heart. Because if you have a normal endothelium, you will never have a thrombus formation in the coronary artery. And it is very important to remind you that the modern theory for atheroma formation and progression consider that there is a struggle between the death and the regeneration of the endothelium. And this is very important It's very important for you to realize that the endothelium of your coronary arteries commits a suicide, and it is regenerated almost every 3 months. It is a continuous cycle. I know that we are not used as a cardiologist to this, but I have to remind you that your red blood cells lives 120 days. I have to remind you that your neutrophils lives 7 hours. Have you thought about that? Every 7 hours, in this very moment, millions of neutrophils millions of cells are dying within our body, and they are regenerated. We do not feel it. We do not feel it because this is nature. The life and death cycle occurs in nature. You cannot have life without death. The leaves goes away in autumns and come back in the spring. We die and somebody is regenerated. And it is a cycle which is wanted by nature. And the death occurs because of apoptosis, and apoptosis is an extremely well-regulated process, starting from the nuclei, and there is a biochemical sequence which is destroying the cells in millions of apoptotic body without any reaction, and that is the reason why, in this very moment, millions of cells are dying within ourselves, and we do not feel it. And there is a continuous regeneration. It is our society, in a way, which is considering life good and death bad. But for nature are two necessary processes. And when you have a lack of death, you have cancer. And so this is very important to remind. Now, every 3 months, the endothelium of your coronary arteries commits a suicide and it is regenerated. If this does not occur properly, you will have a hole in the floor of your coronary arteries. And if you have a hole in the floor of your flat, you will have a flooding behind. And that is exactly what is happening. If you have this mismatch, all the biochemical process of atherosclerosis will start and progress. And if you have a normal endothelium, that is the best possible protection against thrombus formation. Therefore, it is quite important to test the capacity of the endothelium to undergo to apoptosis and regeneration. And that is what we have done in a sub-study, the pertinent sub-study of the Europa trial. What we did, we isolated human endothelial coronary cells and when we do that, not the endothelial cells allow to see the coronary body from some position. In this particular experiment, these cells were considered coming from a normal subject or patients with coronary artery disease enrolled into the Europa. And by doing so, we could measure the apoptosis of the endothelium. Oh, sorry. And these are the very important results. As you can see here, in controls, the rate of apoptosis is about 3%. These are the patients with coronary artery disease involved in the Europa trial. Before receiving placebo or before being treated for 1 year with Perindopril. And look, just because these patients had coronary artery disease, they are doing well. These are patients who had a previous bypass surgery, but they are doing very well. They are not necessarily hypertensive. They not necessarily have angina. They had a myocardial infarction 4 years before, or just a very successful PCI. But just because they had coronary artery disease, look, their endothelium is committing more suicide than normal. If you treat them with placebo for 1 year, if something, even higher apoptosis. But if you treat them with Perindopril, you have a reduction of the apoptosis. Not in every patient, but in the majority of them. And if you have an excess of apoptosis, you might expect to have some hole in the floor of the coronary artery, and therefore you have disruption of endothelial continuity, and that is the onset of atherosclerotic process. And if there is a plug which is already, covering, the endothelium is already covering a plug, it will be in that hole there and there that the thrombus formation will occur. And therefore, reducing apoptosis of the endothelium is very important. Now, the question is this a specific effect for Perindopril, or it is just a class effect? Very difficult question. And what we did, we explored this question in some animals. These are rats in which we increase the rate of apoptosis by liposaccharide infusion, and then we repeated the experiments with all these ACE inhibitors on board at a concentration able to reduce the blood pressure by 25%. I'm saying that because in the laboratory I can show you what I want by increasing the concentration. But I use a similar concentration producing similar results on blood pressure. And you can see that enalapril does not reduce apoptosis, trandolapril does not reduce apoptosis, quinapril does not reduce apoptosis, ramipril does reduce apoptosis, and Perindopril does even better. Now, it's very difficult to jump from the laboratories to the clinic, but only ramipril and Perindopril in the clinic produce good outcome results. And this may be one of the reasons, at least. Next, okay. Now, how Perindopril reduce endothelial apoptosis? By which mechanism? Because it reduces angiotensin 2 and TNF-alpha, which are both pro-apoptotic agents, but mainly because it enhances bradykinin, which is a strong anti-apoptotic agent. And also, it is important to realize that not all the ACE inhibitors are the same, and what we want to target is the tissue ACE. And in order to do that, we have finished. And in order to do that, your ACE inhibitor needs to reach into the cell, and there are two classes of ACE inhibitors, those who are liposoluble and those who are hydrosoluble. And only the liposolubles have a higher affinity for the tissue ACE. I go quickly, and And as you can see, Perindopril is the best ACE inhibitors to increase bradykinin. Now, what about, can you follow me with the slides? What about regeneration? You can see that Perindopril, when given to patients with angina, was able to increase the regeneration of the endothelial cells produced by the bone marrow. Therefore, I like to put to you that ACE inhibition is able to reduce the death and to improve the life of the endothelium. Now, what about the ARB? Because this is very important. Are ARB equivalent to ACE inhibitors? The answer is no. And we know that from many meta-analyses showing that the ARBs, if something, they can create even more infarct than reduce it. I go very quickly because I want to show you, can you just follow me, please? Okay. I just want to show you the reason why the ARBs are not protecting against the myocardial infarction. Because, as you can see, angiotensin 2 is able to act on many different receptors, the so-called 81 and 82 receptors. 81 causes vasoconstriction, 82 vasodilatation, proliferation, anti-proliferation, anti-apoptosis, pro-apoptosis. The trick of nature, the yin and yang, the life and death, the opposite. And then nature try to regulate between the opposite. Now, when you are using an ARB, what you are doing, you are blocking the 81 receptor, so the all circulating angiotensin 2 now will bind to the 82 receptor, causing what? Vasodilatation. Very good. Very good. This is the antihypertensive effect of the ARB. But look, it causes also anti-proliferation and pro-apoptosis. And that is the reason why I believe the ARB might cause even more infarct instead of reducing it, because they do not have a good effect on the endothelium of the coronary arteries. Where are the data for that? Here we have been comparing Perindopril with Valsartan. You can see that with Perindopril there is a very clear reduction of apoptosis, no effect at all with Valsartan. And if you look at regeneration, you can see a very good effect with Perindopril, if something, even less regeneration with Valsartan. So, in conclusion, and sorry for speaking so long, the goal of hypertension treatment is to reduce blood pressure and the risk of cardiovascular mortality. This is very important. You have to reduce the risk of cardiovascular mortality. Both ACE inhibitors and ARB control blood pressure and prevent renal outcome. However, ACE inhibitors are far better than the ARBs in coronary artery disease prevention and reduction of overall mortality, even in patients with diabetes. And this is what worries me. If the medical community continues to ignore this evidence and continues to prescribe ARB for hypertension, the problem is that the patients will be deprived by the evidence-based medicine proven benefit of the ACE inhibitors. That is what is worrying me. Thank you very much for your attention.
Thank you very much, Roberto. I think it was a very excellent presentation and was also challenging. And there is a lot of sciences and a few of evidence that is we need to look after. I think we're going to conclude the session with speaking about pharmacology, and it's my pleasure to introduce Dr. Ibrahim Hammasani. He's a clinical pharmacist, and now he's going to focus on the medical or medication in hypertension. So please share with welcoming Dr. Ibrahim.
Good morning. Assalamu alaikum, everybody. My talk will be just a quick summary and a very short talk. It's only 20 minutes. So we'll try to make this, majority of the things is just a summary and repetition of what have been said this morning. So inshallah, we'll get going. So the important thing really, you have hypertensive patients. These patients need to be seen frequently until they really reach their target or close to their target. So every 1 to 2 months, the patient are relatively stable. However, patients with very high blood pressure, they need to be seen more frequently in the clinics. Once patients really approaches their target level, and you've heard a lot about targets this morning, slightly confusing. However, there are two magic numbers: 140 over less than 140 over 19, less than 130 over 80. Both of them are good. It depends on your patient population, depends on risk factor and cardiovascular risk factors. So once patient is stable and they're close to their target, then really you can see them, then you can see them every 3 to 6 months in the clinic. This is a quick intro. Or is this not? Okay. Now, why treat the blood pressure? Several randomized controlled studies and many meta-analyses really of those studies have shown that treatment of hypertension will decrease all major cardiovascular events by 20% and all-cause mortality by 10 to 15% and coronary events by 20% and heart failure by 40%. So you leave your patient alone, patient is treated but not controlled, then you end up with these major complications, or one of them. It's not working. Oh, turn back. Sorry. Okay. Now, really, treatment is very simple. Use any drug, any combination from those 5 groups or classes to treat hypertension. In the past, we used to say, well, use diuretics first, use this first, use that first, and so on. Evidence, and many evidences, randomized controlled studies, meta-analyses have shown these are the first-line 5 classes of medication. Then you can pick and choose. Obviously, there are certain situations where you have to fine-tune it and really zoom in on some specific agents. However, thiazide diuretics, ACE inhibitors, ARBS, and long-acting calcium channel blocker, dihydropyridine calcium channel blocker, and beta blockers at the bottom. So Dr. Abdul Hamid said 4, but I really agree, both the European and even the American now, they emphasize also the importance of beta blockers in patients who are less than 60 years of age, and we'll talk later why younger than 60. Usually combination of 2 to 3 first-line agents should be considered if systolic blood pressure is more than 20 millimeter of mercury above target or 10 of diastolic above target. The use of single pill combination where ACE and ARB is combined with calcium channel blocker or diuretic significantly enhances drug compliance and results in better achievement of blood pressure target. So monotherapy is more or less restricted to the perhaps high-risk patients with the high normal blood pressure like 130 to 139 or grade 1, 140 to 159. Perhaps you can try with monotherapy, just single agent, but majority of time you will need at least 2 agents, if not 3. Hyperkalemia should be avoided all the time. Now let me try this again. Can we have the next slide, please? This doesn't seem to be always working. Now, randomized control studies again described trends. Now, why beta blockers? I put number 5 at the bottom of the 5 classes. Many studies have indicated that the beta blockers have got less favorable outcome on stroke prevention. And as you know, stroke is a major complication of hypertension. And also, they have less favorable outcome on the regression of left ventricular hypertrophy. So this is why the role of beta blockers is in and out, but it depends on risk factor that your patient really is having. So beta blockers directly and partially, their combination as well, may predispose patient for increased risk of diabetes. And this is why we say less than 60, the risk is perhaps less, but as we age and so on, and insulin resistance and dietary habits, then the risk of diabetes becomes really higher in those patients. Combination of ACE and ARBS is really more or less contraindicated these days because of decrease on renal function and GFR. ACE and ARBS are potential teratogens to avoid in pregnancy, and particularly in females with childbearing age. Hypertension in association with diabetes. I'll provide a summary at the end of this, and really I adopted this summary from the European Society of Hypertension and Cardiology, which is very simple. So really in diabetes, ACE and ARBS are really renoprotective, and they're excellent agents to use. Addition of calcium channel blocker is preferred over diuretics here. Reason diabetics really may interfere with the glucose control and may cause glucose intolerance. Addition of a loop diuretic is important if CKD is on board. Now, the hypertension association with cardiovascular diseases. In coronary artery disease, so ACE inhibitors or ARBs, beta blockers, long-acting calcium channel blockers are really the first-line agents. In stable angina, beta blockers or calcium channel may be used as initial treatment. When combination therapy is being used for high-risk hypertensive patients, ACE inhibitors with dihydropyridine is preferred, calcium channel blocker is preferred over combination with thiazide diuretics in coronary artery disease. Avoid short-acting nifedipine. Nobody should be using short-acting calcium channel blocker these days because of the risk of severe hypotension and perhaps coronary syndrome and ischemic attacks. So only long-acting calcium channel blockers are really recommended, and short-acting nifedipine has been really deleted from many hospital formularies. Combination of ACE and ARBs are contraindicated again, and be careful when really in coronary artery disease. Be careful when you're really lowering the blood pressure, not to lower it, not to lower it too much. You know, the diastolic blood pressure not to drop below 60, and then you create a problem with cardiac perfusion. Oops, we skipped one. Oops. Okay. So recent myocardial infarction. Here, the role of beta blockers is really very important. ACE inhibitors as well on top of that. ARBs only if ACE is intolerant. Long-acting calcium channel blocker, beta blocker contraindicated. Non-dihydrocalcium channel be used with concomitant. No non-dihydropyridine calcium channel like verapamil, diltiazem should not be used with heart failure. Now, if we have systolic dysfunction and heart failure, ACE inhibitors, again, always number one. Beta blockers, for sure, and short, perhaps smaller doses first, and you can titrate as tolerated. ARBs recommended if ACE inhibitors are not tolerated. Now, aldosterone antagonists or mineralocorticoid antagonists really became very important in the control of blood pressure in these patients, and this is about 6-7 years ago when those with having a heart failure class 2 to 4, New York Heart Association, sorry, 2 to 4. I'm trying to use the pointer, it doesn't work. So it really emphasizes the role of spironolactone, particularly in the treatment of heart failure. We continue second-line agents making through sometimes hydralazine and isosorbide only if patients are not really controlled with the first-line agents, which is ACE inhibitors and calcium channel blockers. So hydralazine and isosorbide could be used only in heart failure. Dihydropyridine, calcium channel can also be used. ACE and ARB combination here only in heart failure could have been tried, There's still an option, but really the risk of having increased serum creatinine and perhaps decrease in GFR is very risky. Thiazide like that or loop diuretics are recommended as additive therapy in all heart failure conditions. Left ventricular hypertrophy, ACE inhibitors number 1, ARBS, if not tolerated, long-acting calcium channel blockers or thiazide like diuretic. Direct arterial vasodilators, hydrogen monoxide here are not to be used and are contraindicated. Now, post-stroke or TIA. Stroke is a big problem. What you need to do, you need to really lower the blood pressure very gradually and very slowly. And really, a reduction of approximately 15 to 25% in the first 24 hours is very reasonable. But you also need to involve a neurologist here and a specialist because really it's very critical. You don't want to compromise circulation to the brain. Oops. So non-diabetic CKD, chronic kidney disease, ACE and ARB, of course. However, combination with diuretics and other agents may be used. Careful monitoring of renal function and potassium. One of the major problems with ACE and ARB, perhaps decrease in serum creatinine and decreased perfusion to the kidney. This may occur within the first 2 to 5 days, but up to 3 weeks of treatment. Now, as much as 30% increase in serum creatinine could be expected. More than 30% increase in serum creatinine is not accepted, and perhaps here a change in therapy will be really needed. However, from my experience and a lot of your big practitioners, majority of patients will have a slight increase in serum creatinine, like perhaps in the 5-10% ratio, and not more than that. In renal vascular disease, remember, if you have bilateral renal artery stenosis, then the use of ACE and ARBs is contraindicated because of the failure, because of risk of renal failure. So this is something, if you have unilateral, then it's not really a problem. Major complication. Now, I should really say here, if you've noticed in one of the first slides, I put diuretic on top of the list. Cost of the medication seems to be one of the major important factors in treatment and patient compliance for hypertension. In the Middle East, majority of patients do not have a free national health coverage. Big proportion of our patient population cannot afford the medications. They pay out of their own pockets. Now, guess what? Diuretics still very cheap. The old generation ACE inhibitors are very cheap. Some calcium channel blockers are cheaper than others. Some older generation beta blockers are cheaper. Now, the message is use any medication to control blood pressure. So guess what? If a patient doesn't have any coverage and cannot afford to buy the expensive agent, then I believe you can really stick to any of the 5 classes that we mentioned initially, provided the patient can afford the treatment and he gets and really complies with your prescription. Otherwise, you cannot control the blood pressure. Now, another thing that you need to keep in mind, some of the major side effects of the antihypertensive agents. Thiazide diuretics are contraindicated in gout and hyperuricemia. They're also possibly contraindicated in the male gender, for example, if they are young males because of sexual dysfunction. They may become a metabolic syndrome. Glucose intolerance is something in pregnancy. They may cause hypercalcemia and hypokalemia. However, the compelling contraindication is really gout, and perhaps diabetes is another thing. This is not compelling, but possible. The beta blockers in real asthmatic patients and COPDs, or high-grade or sino-arterial or arteriovascular, if you have a heart block, or bradycardias, then beta blockers are very problematic. But again, a lot of them may cause also male sexual dysfunction, or they cause a lot of sedation in patients receiving them, at least initially. They also cause glucose intolerance and hyperlipidemia, both for thiazide diuretics and beta blockers. Not all of them, but selected beta blockers may cause hyperlipidemia. Calcium channel blockers, usually the local edema or peripheral edema, lower limb edema, could be a problem. They may also really heart failure, class 3 to 4 is possible. and pre-existing leg edema. Tachyarrhythmia is another good, reflex tachycardia. Calcium channel blockers, the non-dihydropyridine, verapamil and diltiazem, really they're not being very used these days for just the control of blood pressure unless you have to. ACE inhibitors contraindicate in pregnancy and the women of childbearing age if they're really still planning to get pregnant. This is something, but they are common in pregnancy. Previous angiotensin edema, hyperkalemia, cough with ACE inhibitors is very common, and bilateral renal artery stenosis. ARBS, more or less the same thing, but they don't really cause any cough. So they could be an alternative in a lot of situations. Oops. Now, single pill combination has really, many studies have shown that the single pill combination is much more effective in controlling blood pressure because it helps really patients to comply with their treatment. You give one pill containing 2 or 3 medications for the whole day, and this is wonderful. The problem with this is the cost, and this is what I said. You want to treat the patient, or you want to give a patient a very costly medication that he will not buy. So really compliance here and patient financial situation should be taken. However, Europe, Canada, perhaps part of the UK, part of the US, this may not be a very big problem. In the Middle East, this remains a problem, patients affording the medications. And the list of all these medications and the combination, everything are available on Saudi FDA webpage, and you look under drug list, and you will really, drug search list, and you will really find the list and the cost as well. Am I running out of time? Yeah? Right. So I talk about single pill combination. Other antihypertensive drugs, all the other agents, they have specific indication. Centrally acting like clonidine is very famous. Patients not responding. We more or less use it mainly in hospitals. When we discharge patients, it causes severe postural hypotension and risk for fracture and fall. Alpha blockers, if you have patients with BPH, non-dihydropyridine calcium channel blockers, they have specific indications. The vasodilators, we talk about them in heart failure, and mineralocorticoid like spironolactone is an excellent add-on medication these days to control uncontrolled blood pressure. The summary now, only allow me with this. I have 3 slides, and really I adopted this completely from the European, and really the European guidelines are excellent, very detailed, and very simple, and perhaps the clearest. Don't forget really the Saudi SHMS guidelines are excellent, to be honest. But these just came recently and did a bit of differences, really, and they're very well structured. If you really quickly look at this, ACE or ARB and calcium channel blocker, plus or minus, diuretic are there most of the times, and that's spironolactone. Very simple. Again, you have cardiac here. Same thing, ACE or ARB, beta blocker or calcium channel blocker, and you throw in a diuretic here. Oops. And finally, last slide. It's not going back. Thank you very much. Oh, it went back, but it's a bit too late. Thank you very much.
Thank you, Dr. Ibrahim. I'm sorry for the time. May I invite all the speakers, please, to come to the podium? Roberto? Yes, Ibrahim, please. Walid and Dr. Ratel. Okay, so we'll like now to open the floor for the questions. Ibrahim, let me just start by you. Now, the guideline clearly indicating the importance of having a single pill combination. All the clinical pharmacists in different hospitals are very resistant to this concept. Yeah, single pill combination for hypertension management.
My hospital is also resistant to this.
Why is this, although the guideline is very clear?
I can tell you. We only have perhaps a couple of combinations. Hyazar, if you allow me, and Hyazar and the other, and Fortzar. This is the only combination we have. The problem is really inventory and the cost. Remember, hospitals, Can you hear? Near? I'll keep it near. Yeah, thank you. This one requires to be very close to the mouth. Okay. So really, majority of hospitals they really wonder about first maintaining the inventory and the cost of the inventory. But really, a lot of time, in the hospital, you have supervision from nursing staff and physician. In the community, you don't have this. So I have a patient admitted in the hospital. Now remember, many hospitals in the UK, and not only in the UK, many hospitals in Canada and the US, you only treat patients while they are hospitalized. Then you write them a prescription to buy from the drugstore. Over here, the situation is slightly different. You see them, particularly in a big hospital and governmental hospital, you see them as inpatient, you also see them in the outpatient, and you give them inpatient medication, outpatient medication. In the West, this is not the case. You prescribe, you give them medication, they buy it themselves, or they have insurance coverage, then the insurance will pay. So hospitals here tend to spend much more on medications, and really add the single pill is really adding inventory and adding cost and increasing the drug budget. Well, your drug budget will mainly be going to the difficult to treat conditions, equipment, and so on. Dr. Wali Basata wants to have state-of-the-art technology for his cardiac, whatever, imaging. I want the oncology department wants to have state-of-the-art medications. Transplant patients are very demanding, and so on. So you cannot really afford to buy most of these single pill combinations. Particularly, you have somebody being treated under supervision in the hospital. This is really most of the time how people really look at it.
Thank you. I think the issue is really more than that, but I think the time doesn't allow us for this. Now, Roberto, the question to you, I mean, you show us a very good evidence about the difference between ACE and ARB, but all the guidelines does not showing that difference. As a matter of fact, we always, in open any guidelines, always ACE is the second phase for ARB.
This is a very important question. I'm afraid is a very political question, and I have to be careful in what I'm saying. The guidelines, if you read them properly and carefully, if you read the text, they clearly say that ACE inhibitors are more cardioprotective and there are more data than the ARB. However, we are reading the guidelines very quickly, always looking at few sentences, and the sentences says ACE inhibitors or ARB if ACE inhibitors are not tolerated. And it is in this if they are not tolerated that there is a lot of confusion. Because particularly for hypertension, all suddenly the ACE inhibitor produce 20 or 40% of CAF, which they do not produce the same CAF in patients with heart failure, for instance. So when I'm said it's a very political and I have to be careful is because even the guidelines how to say, there are lobbies, and you try to understand me, and so there are pushing. Now that the ARBs are all become generics, you will see that CAF is less of a problem with the ACE inhibitor, and there will be less lobbying. But that was the situation, at least in Europe. Because you shouldn't forget that the ARB were somehow created in order to overcome the ACE inhibitors because they were becoming generics. And they have been done with a good purpose, and of course, and in the hope that they could really represent an advantage. But in this particular field of cardioprotection, unfortunately, this advantage is not there, and it has been shown by many meta-analyses. And but you know, people sometimes are under the influence of marketing and so on, and that is what is happening. That is my personal opinion, at least.
Yeah. I have, if you allow me, I mean, one question to Professor Peterson. I mean, always when we hear about guidelines, we hear about target or goal in the guidelines. And it's very confusing to me. I mean, I'm working in hypertension, and this is very confusing to me. Hypertension and coronary artery, hypertension and heart failure, hypertension and stroke, and renal and diabetes and whatever. The goal is different from even from one age to another age. I mean, what is your comment? I mean, our problem is to control the blood pressure as much as we can. But I mean, how we can remember always, most of the time, the goal and the target for blood pressure goal from different patients, and sometimes we have one patient who has 3 problems at the same time. So tell me how we can manage for the goal. Thank you. Difficult question, I know.
It's a very difficult question because, in my opinion, yes. Yeah. In my opinion, acceptable range tension blood pressure range is acceptable range 120 to 140 acceptable range, better than one target number. If they have hypertension but coronary artery disease and diabetic patient, very low systolic blood pressure and very low diastolic blood pressure increase the mortality.
Next to your mouth,
Therefore,
microphone.
The target range.
Yes, thank you.
We have the focus the target systolic and diastolic blood pressure acceptable range 120 to 440 systolic and diastolic only 80 millimeter mercury. Strict range. Over the very low hypertension may be dangerous for increasing mortality, increased hospitalization, heart failure. Therefore, acceptable range is better than one target number, in my opinion.
Okay, thank you very much. I think we have a lot of questions, but because of the time, we have to conclude the session. Thank you very much, and inshallah, see you in the next session. Assalamu alaikum.
Comment was, don't worry. Just
Just
use the
live.
bloody pressure.
Just do the medication.
Yes.
Control the blood pressure. I agree.
Just one second for the speaker, please. Can you stay, Dr. Roberto? Just 1 second. The lunch and the prayer will be in the Dunya B. Thank you. I will just have a plaques and certificate for the speaker.
Thank you, sir.
That's great. Where are we having like downstairs? Okay.
يكون عافية.
1 2 1 2 خلاص طيب احطه في جيبي. طيب والبوينتر سوري هذا how you turn it off.
الصغير هذا
وين اوكي
حركه حطيت في اللمبه الخضراء.
Okay. In normally, alt 5 is okay. It's okay. It's very comfortable. Yes. Please help me during my presentation. Okay. And the second one, the first one, the doctor from Saudi Arabia, and second one. You went for lunch? Yes. عليكم السلام.
لما نبدا
الشاشه متشغله شغاله بس هو هم استخدموا على سويتش يشوفوا دايما السويتش ما كمل. He want to try to connect the cable to the switch.
Okay. Okay.
That's why.
Enough for me outside.
Hello, hello. 1, 2, 3. You have to just put your mouth near me.
Okay, okay.
Because the voice is
I will arrange, no problem for me. Okay.